Yeah. Good.
Okay, so thank you everyone for joining in today. Very good morning and good evening to all of you. And we have a very special guest today with us, Dr. Preet Randhawa, who is a renowned cardiologist. And we have Sunny, our CEO, with us as well, who is so passionate about this whole initiative that he keeps us getting these experts to share their knowledge with us. So thank you, Sunny, for that. And thank you, Dr. Randhawa, for joining in. Over to you, Sunny, if you want to say a few words for Dr. Randhawa before we
Yeah,
start.
thanks, Shruti. Yeah, so Dr. Randhawa is a very accomplished cardiologist, and he has worked in many different health institutions, and now he has over 100 people, private practices in the area of New York City, and yeah, so and he's a friend. He keeps me fit with our tennis game, both. Yeah, so our kids and we both play tennis together. So that is one way for me to get support from him for my heart. And so yeah, so we were talking, we had a sleep doctor, we had some other experts. We never had a heart doctor. And heart is actually at the center for everything. So we're going to learn about healthy heart practices today. And Javed is like, I'm very excited about my heart best practices learning right now. So over to you, Dr. Randhawa. Thank you so much for coming and contributing to this community. We appreciate you.
Yeah. Well, thank you for inviting me. I think this is a very good, it's a good idea to, as a company, as a business, not just to focus on the business, but to focus on the well-being of the staff, well-being of the employees, and well-being of the whole team. I think that's a great way to set up a company, which is basically not just employees. These are, part of the team. These are team members. They're a part of an extended family, and to focus on health and all of the other incentives that make their life better quality. I think that's very excellent. I think many other companies could learn from this example and work on welfare of their own staff here. So much appreciated. Here we go. Let's start with the conversation. So I'm going to go into the share screen, so you will lose me because I want to show you the slides. So let me know if there's any problem in audio, but here we go.
We can see your screen and the presentation.
Okay, here we go. Let me make sure I can do it in a slideshow. Okay, so we see that now.
Yes.
Okay. Okay, so, basically the talk is about preventing heart disease. Here we go. I think looks like it cuts off my slide a little bit on the side. Maybe I can move this. Okay, here we go. So the most important way to prevent what we call in medical lingo is atherosclerotic vascular disease. It's just a complicated name for blockages in your arteries. So you can have a blockage in the artery that goes into the heart, that can go into the brain, that can go into the kidneys, that can go into the legs. This is a process it's a process that involves the entire body. This is not a process that is restricted to only one part or one organ. So usually when we are treating for cardiovascular disease, you're also reducing the risk of heart attacks, you're reducing the risk of strokes, of blockages in the legs, of kidney blockages. So you can have blockages in any part of your body, and the process is very similar. As we all know, prevention is always better than cure. And not only is it better, it is also very cost effective. If you look at United States, how much money is spent in the United States, basically trillions of dollars, in treatment. And as a doctor, sometimes that's one of the things I have a problem with our healthcare system is there is too much emphasis on treatment and not enough emphasis on prevention. Prevention can sometimes be much more cost effective and much cheaper. And as we know that a normal artery, the arteries that you're born with, what nature has provided us, or if you're religious, what God has provided us, it's always better than after we've treated them and instrumented them. So this is a picture of the heart. So if you see these little red arteries, they look very small, but they're extremely important. What these arteries are doing is they are supplying blood to the muscle of the heart. As you know, heart is basically a pump. It's a muscle with 4 chambers, and the only job of the heart, the main job of the heart, is to pump blood to all the different organs of the body. And to be able to do that work, to be able to pump, the heart needs energy and nutrition and sugars and fatty acids, and the way that is provided is through these little arteries that go to the heart. So if you look on this picture, this is what a normal artery looks like. For a young person, a 20-year-old person, a 25-year-old person with really no medical problems, that's probably what the artery would look like. It's very clean, it has 3 layers, the blood is flowing through nicely, and there's no problem. When you exercise, you can get plenty of blood flowing through the artery to the heart. This is what a blocked artery looks like. So you have a buildup of plaque. Most of this plaque ends up being cholesterol. And so the narrowing, the lumen, the area of the artery has significantly reduced. And there's a very small channel left for the blood to flow. The blood can still flow through this. Even though this looks very small, this is enough blood flowing through to not cause a heart attack. But what happens is when you start to walk, when you exercise, when you're climbing stairs, there's not going to be enough circulation. You cannot push enough blood through such a narrow channel. And people will start developing symptoms of chest pain, or they get short of breath, or they have all these symptoms that are related to, coronary artery disease. So the question is, before we go into prevention, is how do we normally treat this? How do we clear up this blockage? And, there's 2 main ways to do this. One is, which is what my specialty is, we do what's called a stent. So if you see the artery over here, the artery has, a blockage, and you see this little piece of equipment that we put it across the blockage. Most times, we enter into the vascular system either through your wrist or through an artery in the leg area. If you feel in your leg area, you can feel a pulse. Usually we'll put a needle through that. And once we are into the arterial system, there's a way we can move equipment relatively quickly, in and out. And we get into the artery, and, we don't need to go into all the technical details of how that's done, but just in a nutshell. So this is a stent that is sitting across a blockage. When we expand the stent, there's a balloon that is inside the stent, and the stent will expand. And after that, you collapse the balloon again, and you take it out. But the stent stays in place. The stent is like a scaffold. You see a building where there's construction, there's a scaffold outside. So once you expand the stent, it stays expanded. It does not collapse back. And it stays in the artery. And most times on the stent, they have medications or drugs that are embedded on top of the stent, which gets released slowly to prevent this blockage from coming back. Usually once you have a good result, the risk of a reblockage in the same area is probably less than 10%, let's put it like that. There's a 90% chance of long-term success. The other way to treat a blockage is to do a bypass. This is done with open heart surgery. You basically, not all blockages are suitable for a stent, so Some of them are very easily treated by a stent. Some of them are more easily treated by a bypass, and some of them are in the middle. It's a gray zone. You could use either way. And a lot of times we have conversations, we have a multidisciplinary discussion, and we review the options and we see what's the best approach. So in a bypass, you make a new channel. It's like basically you're going to, from Chandigarh to Delhi, and there's a blockage in the road. So there's a bypass from the side, and that will allow the blood to flow. And this is what it is. So you see this blue thing. This takes the blood from the aorta and brings it directly into the artery. Instead of the blood going through the native artery, it is coming through a different channel. As long as the blood gets into the artery beyond the blockage, everything is fine. Over here, this is artery from the neck. It comes down and it hooks up to the artery of the heart. This is what a heart attack looks like. So you see this artery, there's a lot of all this yellow stuff. This is all buildup of a cholesterol that is in the artery. And sometimes what happens is you have a little rupture of the plaque. And the moment the cholesterol is exposed to the blood flow that is in the artery, you get a formation of a big clot. And now the artery is completely blocked. And once it's completely blocked, that's a problem. And that's where you get a heart attack and you're starting to get muscle damage. That's an emergency situation. For a heart attack, the immediate risk of death is probably 25 to 30%. But if that doesn't happen and you make it to the hospital, still about 6%. But usually if you make it to the hospital, we have a lot of techniques. We can go in, we remove the clot, we put stents. So, you don't want to be in that stage. So that's the dangerous and risky stage. So how do we prevent heart disease? So that's just, in a nutshell, what heart disease is and what different types of diseases. So usually we're using, like a team-based approach for essentially prevention of heart disease. And the physicians we recommend that should use, also we need to see in a social context. We have people from the United States over here, we have people in India, everybody's social context is different. So when we are making recommendations, we need to understand the social context of where the patient is coming from. And it's a combination approach, it's a combination of using medications, using nutrition, using risk factor modification, using exercise. It's a combination of things, not one or the other, to reduce the risk of future events. So the question is, who's at risk? Who are the people we're trying to identify? The people who are in the age of 40 to 75, and they are evaluated for prevention. The way we do this is, there's a standard way of all of the risk factors, but in addition to the risk factors, you can actually calculate a score. You can calculate what is the statistical risk for somebody over the next 10 years to develop vascular disease. And once you determine the risk factors and determine the statistical risk, you can have a much more informative conversation with the patient about medications, about blood pressure control, about cholesterol control, about aspirin, about all of the other risk factors, that we'll talk about briefly that reduce the risk of heart disease. So starting first of all adults should consume a healthy diet, more vegetables, more fruits, more nuts, more whole grains, lean animal proteins, more fish, and reduce the intake of trans or saturated fats and red meats and processed foods, and refined carbohydrates, sweetened beverages, Coca-Cola, Pepsi. There's too much, especially in the West and United States. The diet is very rich. There's sugar everywhere, there's salt everywhere, and processed foods everywhere. So, which leads to a lot of overweight and obesity. So the starting point of everything is a healthy diet, smaller portions, a balanced diet, and making healthier choices on what you're eating. and less meats and more vegetables and more whole grains. So the adults should engage in at least 150 minutes per week of either moderate exercise or 75 minutes per week of vigorous exercise. And usually in most of the statistics, they say you actually don't have to be super aggressive. You don't have to be running marathons to be healthy. A brisk walk, that's 3 to 4 times a week is probably as good as more aggressive exercise. And people that exercise, they have a lot of benefits. They lose weight, they have better muscle mass, they have more balance. Blood pressure is better, diabetes gets better, cholesterol gets better. In addition, people who exercise regularly, the mood is better. Our bodies, they release what is called endorphins. Endorphin, just a fancy word, it's actually, they are chemicals like morphine. So your own body will release things that are similar to morphine that actually improve your mood, that gives you like a high after exercise. And the people that do more exercise, they tend to feel better and they are, healthier. So now starting with the risk factors for heart disease. So one of the most important risk factors is diabetes. People that have diabetes, most times it's related to family history. People have a family history for heart disease. Give me 1 second. So most times the diabetes is related to family history. The other thing is related to being overweight. A lot of the diabetes in the United States is related to obesity. But again, even in India, this is a problem that is rapidly rising in India, and the incidence of diabetes is increasing rapidly. So how do you improve diabetes? You improve your diet. You reduce the intake of sweets, you reduce the intake of pinnies, you reduce the intake of carbohydrates, of sugars, and you do more exercise, you reduce your the waste, and once you've done all of those things, once you've made a good choice in your diet and exercise, if it still is not a target, you need medications. So these are just a couple of names. I mean, you don't need to know all the details of the names, but for people that have diabetes, when they're having a conversation with their physician, usually in the United States, the recommendation is first line drug is metformin. Anybody that is diabetic, they may be on it. The second line, usually we use what's called SGLT2 or GLP-1. You guys don't need to know into the details of what the drugs do, but if you're diabetic, maybe have a conversation with your physician that you're on the appropriate drugs. All adults at every healthcare visit should be assessed for tobacco use. So that is the second risk factor. So we spoke about diabetes. Tobacco is an extremely bad risk factor for all sorts of vascular disease. And the recommendation is when people come to see us, I talk to patients all the time, people smoke a lot. You have to discuss tobacco use and you have to advise them that they need to stop smoking. Smoking is not only vascular disease, it's heart disease, increased risk of stroke, increased risk of cancer, increased risk of lung damage, oral cancers. I mean, the list for all the bad stuff that goes on with smoking is very extensive. There's really nothing that is positive about smoking, and it's one of the strongest risk factors. And especially when things are added. So for somebody that has diabetes and is a smoker, that's even more terrible because it's not 2 + 2 is 4. It's 2. It's 2 + 2 is 9 in this case because those risk factors, they multiply. Another issue is people always talk in the late term. They say, well, aspirin is good for heart disease. We have more and more information. They're saying that if you have heart disease, aspirin is a good idea if your doctor recommends to you to take an aspirin a day. But for the general healthy population that does not have known heart disease, do not take an aspirin a day. The side effects for the aspirin are more than the benefits of the aspirin. So you should use it only if your doctor tells you that that's something you need to use. The next risk factor, we've talked about diabetes, we talked about smoking, is cholesterol. And again, that's a very, very common problem. In fact, in the South Asian population, in the Indian population, this is actually quite a big problem. We tend to have higher cholesterols. So there's two types of main cholesterols. One is the good cholesterol, which is called HDL. One is the bad cholesterol, which is called LDL. Indians tend to have a higher bad cholesterol and a low good cholesterol. So that increases the risk for vascular disease. And again, so you have a blood test. When you see the blood test, you'll see your total cholesterol. You'll see a bad. You'll see the good cholesterol. And for people that have elevated cholesterol, again, the physician will decide, and based on what your risk score is, that needs to be treated appropriately. Especially people that have diabetes and have high cholesterol, again, extremely high risk. The treatment needs to be much more aggressive. Overweight, that's another risk factor. For people that are overweight, weight loss is recommended through healthy. I refer patients to the nutritionist, to the dietitian all the time. We all make mistakes about what we eat and the quantities that we eat. So if you lose weight, it'll improve your blood pressure, improves your cholesterol, improves the diabetes, sleep apnea. There's a lot of comorbidities that are related to being overweight, and weight loss can help improve a lot of other risk factors. The next big risk factor is high blood pressure. So people that come in, the target goal for everybody should be a blood pressure of less than 130/80. And for people that have a very mild blood pressure, mildly elevated blood pressure, the goal is not to, the moment the person walks in, is to start prescribing medication. So the first thing is healthy choices. For somebody that's overweight, they need to lose weight. Somebody that eats too much salt, they need to cut down on salt. Somebody that is drinking heavily, they can reduce alcohol use. Sleeping properly, just more healthy choices. And that sometimes by itself will improve blood pressure control, especially for patients that are very obese, that are very overweight. Weight loss can produce a significant improvement in the blood pressure. So those were all the major risk factors, for heart disease. Now this is very interesting. So you guys can download this, and actually want to show you how these things work. So this is called atherosclerotic cardiovascular disease. It's a risk estimator. So this, you can download this. There's a web version for it. So if I may, what I'm going to do is I'm going to exit out of this slide and show you how this risk calculator works. So let's go. Here we go. Let me see. Okay, so are you guys able to see the screen?
Yes.
Yes.
Okay. Okay, so this is the website. I mean, I can share you this this tool. I mean, this is relatively straightforward. So we can start with hypotheticals. So let's talk about. We're just going to enter numbers here, okay? So and if you guys have at home, you have your blood test results. You know what your blood pressure is. You know what all the different things are. You can enter this information into this calculator, and it will give you a risk score. So for example, let's look at somebody that's, say, 55 years old, is a male, is white, say the blood pressure was 150, okay? That's your systolic, the upper blood pressure. The lower blood pressure is 95. Say your total cholesterol is 240. Say your good cholesterol is 35. I mean, these are numbers that are very easy. If you look at a report of your blood test, you know, all these things are fairly self-explanatory. Say your cholesterol, your bad cholesterol is 160. I'm just pulling numbers out of thin air, you know. Somebody has diabetes, they smoke, they're on treatment for blood pressure, they're not on a cholesterol medication, and they don't take aspirin. Okay. Okay, so can you see on top, it says the 10-year risk for heart disease is 43%. So all the numbers I picked a person that was pretty high risk. They had diabetes, they had smoking, they had poorly controlled blood pressure, they had high cholesterol, they had all the bad habits. The lifetime risk is 69%. Optimal risk is only 3.6%. 10-year risk is 43%. So this is, statistics, is extremely important. We all think nothing bad is going to happen, but you can fight statistics. So any one of you, you can use this calculator, get a copy of your blood test, check your blood pressure, and it will give you a score on what your risk is for 10-year risk is for cardiovascular disease. So these are the factors we're looking at, as I showed you on the test, sex, male or female, age, race. They don't have a special column for Indians. It's only, white, African-American or others. This is based, the algorithm is developed in the United States, so they're not looking at other people, but total cholesterol, so, relatively straightforward, and give you, it'll give you a score. So basically you calculate the risk score and you really know where does it you stand in terms of risk. And once you know what your risk score is, you know what the risk factors are, and then this is where you start having a conversation with your physician about how to reduce the risk. So you need to treat high cholesterol. You need to have a conversation. You need to have, choice of drugs. You need to have healthy lifestyle. You have to manage all the risk factors that we talked about, and then have a conversation with the patient. All of this stuff has to be individualized. Let me see if I can take this to the slideshow. It's a little easier to see this. Okay. So in addition to these, what are the additional risk factors? So these are the main and the most common risk factors, that besides, type 1 personalities or people being very aggressive. Some people have a very strong family history for heart disease. If you have men in your family at age less than 55 with a heart attack, or women less than 65 with a heart attack or heart disease, that's an extremely high risk factor, and your genetics cannot be modified. But if you have high risk, you have to be very careful, and you need much more aggressive control of your risk. High cholesterol, of course, that needs to be treated. That increases your risk factor. Metabolic syndrome. We see this in the United States all the time. It tends to be more obesity, but India's heading very quickly to all the bad habits of the United States, where people have a lot of increased waist circumference. They have high triglycerides, they have high blood pressure, they have high sugar, they have low HDL. That is a good cholesterol, very common among Indians also, and increases the risk for heart disease. Kidney disease, you look at your blood test, you'll be able to see what your kidney function is. People that have problems with kidney function, even, moderate worsening of kidney function, they're at a significantly elevated risk for heart disease. And all of these factors, they multiply, with the known existing factors. People that have inflammatory conditions, people that have rheumatoid arthritis, lupus, psoriasis also increases risk. People in women, people that have early menopause, higher risk for heart disease. Race, South Asian ancestry, Indians. The Indians tend to have very small arteries. It's very interesting. You see on catheterization, when I do these procedures, you see, not to stereotype, you see a big black guy who's 6 foot 2 inches tall. You look at his arteries, they're big, 4 millimeters artery. You see a little Indian guy, or a Bangladeshi guy, the arteries are 2 millimeters, very small in size. There's no good treatment options for small arteries. So that significantly increases your risk of cardiovascular disease. The other things that you can test is, C-reactive protein. This is stuff. This is for people that have a strong family history for heart disease. Tell your doctors they need to do this test. It's called LP small a. It's, just a, I don't know how to explain this, but this is a type of cholesterol, and that is strongly associated with people that have a strong family history for heart disease. Diabetes, people, the longer they have had diabetes, the higher is the risk for heart disease. If they have proteins in the urine, higher risk for heart disease. If they have kidney function, higher risk for heart disease. If they have problems in their vision, higher risk for heart disease. If they have neuropathy, higher risk for heart disease. If they have blockages in the legs, higher risk for heart disease. We can skip through this. This is for people that smoke. We tell them always they need to quit smoking. I'm not sure what's available in India, but usually in the United States, we do different things. We give like nicotine patches, or they use a gum, they use a lozenge, which is basically the addiction in smoking is related to nicotine use. And so what you do is you give them nicotine by a pharmaceutical method, and hopefully they can be gradually weaned off the nicotine addiction. Cigarette smoking is an extremely difficult thing to quit. I mean, I've had patients, who are addicted to morphine and heroin. They quit the morphine and heroin. They couldn't quit the cigarettes. Extremely addictive. So this is not something it's very easy to tell somebody, you need to quit smoking, but in real life, not easy to do. So there's a lot of approaches. So patches, we use all of these approaches to help them quit. You can give the nicotine from a nasal spray, different ways to give nicotine. And then there is different medications you can use. Chantix, that your doctor can prescribe. If there's no, if behavioral changes does not allow you to quit smoking. So, coming towards the end of it, in a nutshell, for otherwise a young, healthy patient is what kind of a routine testing you need to do. I would recommend anybody that's not had a good physical examination, go see a doctor. You can share these slides, it's the CBCs, your blood count, SMA12, I don't know what these things are called in India, but this is basically all the chemistries. You can check your thyroid. You can check a cholesterol panel. You can get a urine test, CRP, get an EKG. And then this is a very important thing, hemoglobin A1C. That is basically something that gives you a lot of information about your diabetes. Just discuss it with your doctor, and have a conversation. For people that are at high risk for heart disease, we've used a calculator, the risk factors. So going through the risk factors again, age is a risk factor, male sex is a risk factor, high blood pressure is a risk factor, diabetes is a risk factor, smoking is a risk factor, family history for heart disease is a risk factor, type A personality is a risk factors, and then all of those other premature family heart disease. We spoke about all the other aggravating factors. So there's no easy way to predict. This is basically, all of this is statistical evaluation on who's at high risk, who's at low risk. So people that are at high risk, they need more aggressive treatment. People that are low risk, you can treat them more conservatively. For people that are at high risk for heart disease, you can get an echocardiogram. Echocardiogram is basically an ultrasound of your heart. You do an ultrasound, you can look at the heart that is pumping, you can look at the heart that is beating, you can look at the blood flow through the heart, and it tells you what the structure of the heart looks like, what all the different valves to the heart look like. The test takes 10 to 15 minutes, and gives you lots of information about the health of the heart. You can do a treadmill test. It's very easy. In the United States, we tend to do more of this. You can do a nuclear stress test or an echo stress test that helps determine if there's a blockage, or also does what's called risk stratification. Are you high risk, medium risk, low risk? You can do a CAT scan of the heart. And then for people that are high risk that have ongoing symptoms, it's called a catheterization, which is what I showed you before, where we go through the leg and we take pictures of the arteries of the heart and we determine, if there's a blockage. So I think that is pretty much what I had in a nutshell. So I think we're doing pretty good on time. So maybe we have some time to, take some questions over here. And let me see if I can get out of this. How do I get back to here we go, let's.
You need to just stop sharing it. You might be getting like a, otherwise I can just.
Yeah, it's okay. I mean, I see everybody here. So that's in a nutshell. It's, as I said before, that most of the treatment, most of the approach to heart disease and cardiovascular disease is actually a preventive approach and not a treatment approach. And when you understand the risk factors, when you understand how to calculate your risk for heart disease, you can see where you are and you can take measures to reduce your risk in the future. And actually, if people that play with the calculator, so for example, if you change the numbers in the calculator, you'll be able to see if your bad cholesterol drops from 160 to 95, it'll tell you your risk is reducing. If you quit smoking, it'll tell you your risk has reduced. If your diabetes is better, it'll tell you your risk has reduced. So if your blood pressure improves, it tells you what your future risk for heart disease is. So, these are relatively easy. All of this information in this, in 2023, in this day and age, is available online at the fingertips. You can download it on a mobile. You can download it from Google or, iTunes, and look at your own risk. And I think the other important thing I always advise people is it's important to be involved in your healthcare. It's important to be involved in your own healthcare. The more educated you are, the more you understand, the more involved you are. When you go speak to a doctor, you can understand the conversation a little bit better versus people that are not compliant, that we tell them to do X, Y, and Z, take the medications, they don't take the medicines properly, they continue to eat healthy diet. You don't want to be in that, and they end up then having more problems and needing a lot of procedures, which all have risk. There's no procedure. I showed you a procedure of a stent. We do thousands of these procedures, but there is risk involved in all of those procedures, and sometimes bad things happen. So the best approach is prevention. Best approach is to be involved in your own healthcare. Best approach is to do things naturally. And when medications are necessary, work closely with the physician and take medications as prescribed appropriately. Thank you. So I'll take questions if I'm sure some of this stuff was a bit technical. You guys are non-medical people, so anything you didn't understand, I'm happy to answer questions.
Okay, thank you. Thank you, Preet. And now we can ask questions. I know our families, my father has blood pressure, to a couple of things that, very insightful. And we can not only help ourselves, but our families as well. So go ahead with questions that you have for yourself or a family member.
All right, so I did have a question here. So when we were talking about the risk factors for heart diseases, there was one factor that you mentioned, type A personality or something like that.
Yeah.
So could you please elaborate on that? Like, how can a personality be a risk factor?
It is a risk factor. The people that are very aggressive, people that are, type A people are people that are just charged up all the time. They're a bit, what we call hyper. It is your personality type. You can relax a little bit, you can calm down a little bit, you can try to meditate. Usually personality types are very difficult to change. It is a risk factor. It is what it is. If that's the kind of person you are, you are who you are. But it's just to understand that that is a risk factor. But when we are usually making recommendations for treatment, we're not telling people to change their personality. That's not something that's that people can do easily. But it's good to take breaks. It's good to relax. Yeah. In a general, that's probably personalities, not only type A personalities, but there's all different sorts of personality disorders, and those are built into our DNA and into who we are, and that's probably one of the hardest thing to modify is your own personality. People that have anxiety tend to be very anxious. People that are overconfident are always overconfident, and people that are overaggressive are always overaggressive. And as much as we try to modify it, that's the whole. Next time we'll call a psychologist to give you a talk on the personalities. That's a tough thing to do, but it's good to realize that what your own personality is, have some introspection in that, and understand that that could also be a risk factor for cardiovascular disease.
Okay, go ahead, Poonam. We have one more question. Thank you, Preet. Poonam, go ahead.
Yes, thank you, Sunny. So, Dr. Randhawa, my question was similar to this. A lot of times we see very healthy people who have been exercising, working out, gymming. All of a sudden they just crash, while exercising, without even knowing the reasons as to why that happened. So, has that got some correlation with their personality type, or could there be other underlying reasons? Because if they are regular at exercising, how do these cardiovascular diseases impact them?
Okay. So I think that's a very good question. So you see in media, you'll see a young movie star, or you see a marathon runner, and suddenly they have a cardiac event. So the way you have to look at this thing is you have to look at it statistically. You can have the best habits in the world. You could be running 10 miles a day, not smoking, with normal blood pressure, with no diabetes, with no family history for heart disease, and then ask the question, what is the risk of this person having a heart attack in the next 12 months? The risk is not zero. The risk for any person having a heart attack is not zero. So statistically, you could have extremely healthy habits, and your risk for a heart attack in the next 12 months is, say, 0.5%. When you extrapolate that to millions and hundreds of millions of people, somebody's going to be unlucky, and somebody's going to do all the right things and have a heart attack. On the other hand, somebody can have I see patients here who have smoked all their lives, who are overweight, who have diabetes, who have every bad habit that's known to mankind, and they're 95 years old and they're living healthy. That is statistics. The question is you cannot look at the two extremes. If you look at the healthy group, an extremely healthy group, their risk for a heart attack in the next year may be 0.5%. And you can look at the unhealthy group, their risk for a heart attack is 10% in a year. So the risk is, this is only a statistical thing. There's no perfect treatment. There's no perfect risk modification that you could do, and you could reduce your risk to zero. I tell people all the time, you cross the street in the United States, you can be hit by a dump truck, So there's risk in anything that we do. You get on the highway, you drive, there's a risk in it. So, and you're exercising and you have a heart attack, that's a risk. And that risk, there's no way to modify that risk. There's no way to eliminate that risk.
Yeah. Thank you, Doctor. Okay. Thank you for this session.
Anything else? We're all set?
So, okay, doctor, I have a question over here. So, my mom is a blood pressure patient. She is on medication, but it happens in between, and that the blood pressure spikes. And normally now, but what you have shown is that 130 and 80 is normal, but doctors now have said that it is like normal to have 150 and 70, even lower, 1 till 70 for her as well. So this happens quite frequently with blood pressure patient, or we need to go for some other recommendation. Like we have my sister-in-law as doctor as well. She's an eye surgeon, but yeah, I just thought if you have any advice on this.
Well, so usually the upper limit of normal is 140 over 90. So what I tell patients is intermittently you will have a spike in your blood pressure. The goal is not to treat spikes. The goal is not that we're trying that all the time you have a perfect blood pressure, as long as your blood pressure is well controlled most of the times. So sometimes I have patients that have intermittently have spikes. What I tell them is to start documenting their blood pressure. I tell them to check it twice a day, 3 times a day, make a logbook, they write down the numbers, and they bring them to the office. And intermittently, you'll see that, you know, there's a few times in a week, you know, maybe 5-10% of the times the blood pressure is higher than normal, but at most times it's under good control, and that's fine. You're not the heart and the blood pressure is not something that is mechanical, that you're going to get 120 over 80 every time you check it. If you're upset, you're angry, you know, you didn't sleep well, something happened, somebody cut you off when you were driving back home, you're going to have a high blood pressure. But you're not trying to get each reading to be a perfect reading, as long as in general your readings are in the normal range. That's probably adequate.
Okay. Okay,
so
thank you.
Keeping a log is very important, for especially people that are very labile blood pressure. Yeah. Maintaining, and it's relatively easy to do, and there's apps you can do it. They'll average it out for you, you know, you're targeting in general good blood pressure. That doesn't mean that at every moment of every time you'll have a perfect blood pressure.
Okay. Thank you, doctor.
Yeah.
Anybody else?
Yeah. So we still have 5 minutes, team. If anyone else have a question?
Yeah, I do.
Yeah, doctor, I do have.
So
Yeah, please go ahead.
cholesterol is one that I think is a big indicator of your heart health. How reversible is high cholesterol? I know it's reversible to some extent, but at what points are you like really crossing the point of no return? And then, you know, what type of timelines are you looking at to really focus and get your cholesterol and back under control?
Oh, that's a good question. Cholesterol is actually relatively easy to treat. The only problem with that is it requires long-term medication. So if the cholesterol is mild and people have very poor diet and they're overweight and their habits are very bad, you know, you can reduce your cholesterol maybe about 10%, maybe 15%, just making changes and healthier choices. But if your cholesterol is significantly elevated, just diet and exercise is not going to be enough. And there's a lot of good medications. You know, there's statins, there's Zetia, there's injectable medications. I mean, there's a whole slew of medications that are available to treat cholesterol. So, you know, for a patient that is willing to follow through, willing to take medication, willing to watch their diet, that's something that's relatively easy to treat. Most times the problem is actually compliance and people not taking the medication. There's tons and tons of good options to treat high cholesterol.
Thank you. And last question, do things like fish oil really work?
Fish oil works, actually. I recommend fish oil all the time. So especially when you have, if you looked at the breakdown of your cholesterol when I was showing you the slides. So the 4 main types of cholesterol is, one is what's your total cholesterol. Second is what's your bad cholesterol, which is called LDL. Third is what's your good cholesterol, which is called HDL. And the fourth is called triglycerides. So a lot of times people have high triglycerides, and especially when they have high triglycerides, I recommend them fish oil. And usually the good dosage is 1 gram, 2 capsules twice a day. So a lot of times people are taking 1 capsule a day, that's not sufficient. Usually you need 4 grams a day of fish oil. But again, it depends on your breakup. And you know, a lot of this stuff is actually relatively straightforward. You know, most times people just need to be more involved in their own healthcare. And it's not hard to take 2 capsules twice a day of fish oil. And if you have high triglycerides, it improves significantly. And then sometimes that's not enough, and you can add a medication on top of that. Yeah, very good question. Yeah.
Thank you.
Doctor, I have a question right here.
Sure.
Yeah, so my mom has heart disease. Actually, her valve is squeezed from birth, as well as she has asthma, level 2 asthma, and sinus issue. She is heavyweight, but doctor asked us to go for the valve transplant, but we cannot do that because of her asthma. She cannot survive the operation as well. So in that situation, how we can go further?
I think it's it's depending on what valve it is and how bad it is. But just because somebody has asthma, that's not a contraindication for valve surgery. Over here, we treat people that are very sick. I mean, I've had people that are 95 years old that I've sent for valve surgery. That's open heart surgery. Some valves can be treated through the leg, with a stent, but most valves require surgical treatment. But they just have to be seen at a high risk center. I mean, I have rarely seen somebody who really needs a valve operation. How old is your mom?
67.
Yeah. She's too young, and you probably need to go and have evaluation at a bigger center, at a tertiary center. Somebody that's 67 just because they have asthma. We have people that have smoked 40 years in their life. We send them for surgeries all the time. All of this stuff is manageable. You just need to be in the right place. And depends on how bad the valve situation is. I mean, saying there's a valve problem is one thing. How bad the valve is, which valve it is, how severe it is. There's a lot of other intricacies, to it. But that just doesn't sound right. I think that most of these things are treatable. If it's necessary to treat, it should be treated. And if the disease is bad enough, what is the other option? If the valve is so bad, it's only going to go downhill from there, and things are only going to get worse. So yeah, I would get a second opinion. You can email me the echo report. I'm happy to look at it and
sure,
just give you in a nutshell. You can get my email from Shruti. And so just the echo report is important. That that ultrasound will tell you what the different valves are and what's happening. And like I said, most of this stuff is routine treatment here.
All right, great. Thanks, Doctor. Yeah, I'll share the reports with you.
Sure, my pleasure.
Thank you.
One more question I have. So there, you mentioned about C-reactive protein as a measure to look at heart disease as well, right?
Yes.
So there's one more parameter, ESR. So is ESR having some relevance with heart diseases, that if it's higher?
ESR is basically a reflection of this inflammation in the body. So if you have some kind of inflammatory disease, you have like rheumatoid, lupus, sometimes it's an infection, and C-reactive protein can also be a marker for inflammation. And basically the guidelines for all of these is if you have a high C-reactive protein, the treatment is with a statin with lowering cholesterol. So, those are not like the big central risk factors. They're not like diabetes and smoking and high blood pressure. But if there is generalized increased inflammation in the body, which would be indicated by high CRP or high ESR, the recommendation is just be more aggressive with cholesterol control. And usually we treat them with some Lipitor, Crestor, one of those statins. Yeah.
So is it general, like it's in general, it's higher in female bodies, that ESR?
ESR?
Yeah.
It's more related to just inflammation. It's, I'm not sure if there's a sex difference per se, but mostly it's a marker for inflammation. And inflammation is a marker for future cardiovascular disease. So we don't treat ESR, we don't treat CRP. What we treat is if you have high markers for inflammation, you treat with more aggressive cholesterol lowering.
Okay. The reason I asked about ESR is just because the doctor I referred to that reports for my wife, she's having ESR on the higher side. He said like it's generally higher in the female body, so that's what his.
Yeah, I'm not
was.
sure. I'm not sure. You know, I would have to look it up myself to see what's the variation. But again, most times a high ESR is a marker for inflammation.
Okay.
Someplace, yeah. And if it's very mildly elevated, you know, you just recheck it. If it's significantly elevated, it suggests there's some kind of inflammatory arthritis or some other issue, you know, that's ongoing. And sometimes you don't find anything symptomatically, you know, you do. Most times we don't just treat a blood test. You know, if there is some indication of inflammation, you treat it appropriately. Otherwise, some people have a high ESR, and it is what it is.
Thank you.
You can take some haldi every day, Suri.
Yeah, it's getting more popular in the United States too. Yeah, it's a lot of my patients are now taking haldi.
Yes.
Turmeric, yeah, everybody calls it turmeric. Yeah, they're selling it in capsules over here.
Doctor, I have one question as well. I'm looking at my reports, which I got checked like quite some time back, like in June 2022. So wherein it says LDL is 167.
Yeah, it's high.
Okay, and if we talk about total cholesterol, it's 241.
Okay, how much is HDL?
HDL, non-HDL cholesterol 186, and HDL cholesterol is 54.80.
54, yeah.
So
it's high. So
it's high.
I would routinely treat that with a statin. Yeah.
So what would you suggest in this case? Like, how should I proceed about it?
Yeah, I wouldn't normally, when I see somebody like that, I would put them on like 10 milligrams of Lipitor or 5 milligrams of Crestor. I would treat it with medication. Yeah.
Okay.
You know, this, how old are you?
I'm 39.
39, yeah. I mean, it's fairly high. I mean, the more than 160 of your bad cholesterol, you know, the usual target is close to 100. You know, right now, nothing will happen if you don't treat it, but over the years, you know, it has a cumulative effect. I treat it very aggressively. All the studies, all the trials, you know, they show reducing cholesterol reduces future events. You know, I don't know what other risk factors you have. You can try diet control one time, but I would treat it fairly aggressively. Yeah.
No, the only other thing which came out in picture was like just a fatty liver.
Yeah. So yeah, fatty liver, you know. But yeah, I would treat the cholesterol. Yeah, it may be connected. If you're overweight, that can cause fatty liver and high cholesterol. But
on the other end, I do not smoke much.
Yeah.
Like
not
not at all much. Like just as an option. I'm not habitual of smoking or at all.
Yeah.
Socially, you can say, just socially at times.
Yeah.
Or if you talk about drinking, as that is socially as well. Or maybe say 1 or 2 bags on weekend. That is it.
Okay.
That is it.
Yeah. I mean, I think sometimes these things are genetic. Sometimes cholesterol is familial. You know, sometimes it is what it is, and it's better to treat it early. You know, eventually all of this stuff, we all get older, and eventually this is going to cause more and more problems. So I would personally be more aggressive treating it. If my LDL was 162, I in fact take a cholesterol medication, and my cholesterol is significantly lower than that without medication. So treating aggressive cholesterol that's an easy answer. Yeah.
I got it. Thank you.
I have a question. Recently, I've been diagnosed with, not diagnosed, I would say I found that I have a lot of heart issues. It's been 3-4 months now. I'm under medication. My heartbeat is above 120 all the time.
Yeah, I mean, I think that's a bit more complicated. Is a heartbeat of 120? What type of heartbeat is it? Is it a normal? Is it sinus? Is it irregular? You know, so you would have to have that investigated a little bit more. that's not really what we spoke about today, coronary artery disease or blockages. There's lots of different rhythm issues. There's lots of, thyroid or other things that can cause elevated heart rate. So, that's something that, you're going to have to see a specialist and get it all checked out. There's not an easy answer that my heartbeat is 120, so I take pill X. You have to look into this a little bit more to see why the heartbeat is high and what else is going on.
Yeah, I'm into medication, so there are a lot of things that I'm taking. If I don't eat that medicine, the heartbeat goes to 120, 125, even 140. It touches 140 as well. But I'm not pretty sure how long that I need to continue with this. But yes, as soon as I stop taking those medicines, my heartbeat goes to 140, even 130.
Do you have a diagnosis? What have they told you? What's your diagnosis?
I really don't remember. It's been 3-4 months now, and the cholesterol is pretty high. That was pretty thick, so I'm under the medications. The medicine that I'm taking is to control the heartbeat and to control the blood. So it was thick. So they're doing it,
Yeah.
So that's something.
Yeah. I think it's, you need to get a little bit more information. The cholesterol part is easy. This is probably not connected to your elevated heartbeat, but just elevated heartbeat by itself doesn't mean anything. What type of a heartbeat it is, usually we recommend a 24-hour heart monitor. You need to get an echocardiogram. You need to look at your heart function. You need to get an EKG to see really what's going on, and then look at the medications. Yeah. It's very little information to conclusively tell you one way or another, what's happening.
What we can do there, Gaurav, is what Dr. Randhawa is asking in this case, like EKG and other things. So if you already have those, send those reports to Dr. Randhawa. And Dr. Randhawa, if you can please kindly review the information in detail and give your opinion.
Sure, we'll do that.
Yeah. Okay. So I think it's time.
Yes.
Yeah.
Thank you so much, and Dr. Randhawa, thank you so much for coming and sharing a lot of great information here, a lot of insights, a lot of actionable items here that we can take to live a healthy lifestyle. And heart is everything, right? So if our heart is healthy, a lot of other things that we have been talking about, they are relevant, they matter. So please take care of your heart, and with all the great best practices that we have learned today.
Yeah.
And what is in our controllable list?
Yes.
That's what we can control. And thank you, doctor, and thank you, team, for joining.
Thank you so
Thank
much.
you, Sunny, and thank you, doctor.
Thank you, Sunny.
Thank
Thank you,
very
Doc.
much.
Thank you, everyone.
Thank you so much.
Yeah.
Thank
Great project that Shruti you're running. So many congratulations to you.
Thank
job.
you,
Thank
you,
you. Bye-bye.
doctor. It's with the help of Sunny only we are able to run such a project.
Of course. We all do as part of a team. Thank you. Bye-bye.
Bye-bye.
Bye.
Thank you.
Bye.